My name is Anakalor, and thank you so much for being here with me and with Dr. Megpara to talk about new paradigms in the novel neuromodulation-based therapies for dry eye disease. And this is made possible by support from Alcon. And so these are the organizations that are providing the credits. And it's really important to remember to turn in your evaluation by November 2nd in order to receive your CME certificate. And we do have some disclaimers that we have to show you, and also a planned and speaker disclosure policy. Now, we do have some disclosures, and our learning objectives are to integrate the factors contributing to DED, such as the Lacrimal functional unit and tryptamate channels, which regulate basal tear secretion, and to talk about the implementation of novel neuromodulation-based therapies to improve patient outcomes of individuals with DED. And so this is an overview of the agenda. I'll talk for about 30 minutes, then Dr. Megpara will talk for 30 minutes, and then we would love to take your questions. And I thought I would start off with a pre-test clinical vignette. This is one of my patients. She has Sjogren's. She has progressive worsening eye irritation. She's using artificial tears constantly, and it's not working. She also has dry mouth. On exam, her vision is 20/25. She has diffuse PEEs. Her tear breakup time is low. Her Schirmer testing is low. However, her meibomian glands look okay. And the question is, she's already tried preservative-free artificial tears and nighttime ointment, and now we do need to do something else. And you guys all get to vote. We'll put this up for about 30 seconds, so please, everyone vote. What would you recommend? Okay, so lots of different opinions here. And now we're going to move on, and we're going to ask this very same question at the end. Okay, so I get to talk more about the diagnosis. And the reason I love to talk about it is because when people have a variety of ocular surface symptoms, they usually get diagnosed with dry eye. But if you look at dry eye, these patients all look different. And so the thing to remember is that dry eye is not one disease. It's a concept, and there are different phenotypes, different pathophysiologies, and patients need different treatments. So it's okay to use the word dry eye as long as it's considered an umbrella term, but we need to move on and become more specific if we want to deliver precision medicine to our patient. So I think a better approach in this field is to identify contributors to symptoms in an individual patient and to target them. And in order to do that, we need to understand what are the symptoms that patients come in with. Oftentimes, they're lumped into pain, discomfort symptoms like burning, aching, tenderness, vision symptoms, and other symptoms like tearing. And so I like to split up the different types of symptoms, and anything that falls under pain, discomfort, I want to think about nerve activation, because the reason people feel anything is because their nerves are firing somewhere between their eye to the brain. And so really important to see nerve unhappiness and then be a detective and figure out why are the nerves unhappy. On the other hand, when people come in with fluctuating vision, tearing, there I like to look at the ocular surface and all the different components that live there and try to figure out why they're unhappy. So let's focus a little more on the pain discomfort aspect. I like to break it up into two categories. Either nerves are firing because something is irritating them. That could be being poked in the eye. It could be not making enough tears. It could be anatomic issues, or they're abnormal, or you have pain discomfort because the nerves are abnormal. And so the punchline is that under this umbrella of dry eye, there are so many places that can go, or so many things that could go wrong. And I think taking a step back, a nice way to think about it is how everything is integrated. And that's where the concept of the lacrimal functional unit comes in, because the ocular surface is only a small piece of the puzzle. There's a whole network that connects the ocular surface to the brain and back. There's the afferent system that senses and the efferent system that responds. And the word lacrimal function unit is a little bit of a misnomer because it's not just the lacrimal gland, the meibomian glands, the goblet cells, everything is under control. And one of the ways that the system works is by having these sensors at the level of the ocular surface that are constantly asking what is out there in the world. So if you get poked in the eye, there are mechanoreceptors that respond. If you have inflammation, you have polymodal receptors that can sense that. And if you have cooling, which we think is triggered by the evaporation of tears, you have these cold thermoreceptors that sense that. And the way they sense it, they have a cation channel at the level of the ocular surface in the terminal nerve endings. It's called TRYPM8, and it gets triggered and sends information to the brain. And the brain responds and causes tearing, causes blinking. And so these are kind of the first line to try to figure out or help the ocular surface figure out how to stay healthy. Now, unfortunately, when we see a patient, we don't understand which molecular component is not working well, but we do know that when you look at the ocular surface, there are many things you see that may explain symptoms, but that's not enough. We also have to think about the nerves and the entire lacrimal functional unit when we think about our patients. And so again, it's about being a detective. And how can we be a detective? We have to do a comprehensive but quick exam. We start by looking at the periocular skin because we're periocular dermatologists. Then we go to the lid margin. We're looking for different signs of meibomian gland dysfunction, blepharitis. Then we're looking at the quality of the tears, the staining pattern, and I like to look for tear production or the tear lake. And why is this important? Because if you do this quick but comprehensive exam, sometimes you do find dry eye. This is a low tear lake and a low Schirmer and interpalpebral staining. And this is one of my patients who also happens to carry a water bottle. But it's really important to realize that not all epithelial disruption is the same. There are different patterns, and sicca, dry eye, is generally interpalpebral. But sometimes you see this central snowflake pattern, and that's more common with NK. And sometimes you see PEE that are touching the limbus. That's more common with eyelid exposure issues. And so the key is it's not enough to just say, is there disruption? It's important to look at the pattern. After I try to understand that, then I try to understand, is there inflammation contributing to symptoms? And I do have a point of care test. It's called the Inflammadry that qualitatively measures MMP9, but you could look at the intensity of the stripe to get a sense of how much inflammation patients have. And I always ask if I see inflammation, is this a finding localized to the eye, or is this part of a systemic disease? And especially when I see a lot of inflammation, I'm always thinking about Sjogren's. And so Sjogren's is tricky sometimes because it's itself a heterogeneous condition. Well, what I'm looking at are clues both at the level of the ocular surface and the body that can suggest that there's an autoimmune component. I'm looking for decreased nerve density and what we morphologically define as these activated dendritic cells, which we have shown can help identify patients who may have an autoimmune process. More needs to be done, but it's a suggestion. And so my patient actually did have at least 2 morphologically defined activated dendritic cells. And so I thought, well, maybe this could be Sjogren's. And in 2016, in order to make a diagnosis of Sjogren's, you have to have positive serologies and either corneal staining or a low Schirmer test. But it's important to realize that there are other ways to get a diagnosis of Sjogren's based on a biopsy or salivary flow. And so when I see patients, they either have Sjogren's and they get sent to me to say, do they have dry eye? Or they have dry eye and I'm trying to figure out, do they have Sjogren's? And this is where our patient is. But unfortunately, when you test patients, many of them are negative for the diagnostics test for Sjogren. That's the SSA. But now there's a new test that people are using, and it's called early markers of Sjogren's, but people aren't really sure that it's truly early markers of Sjogren's. It's not really clear what it's an early marker of. But I can tell you that many of my patients who look like they have Sjogren's, but have a negative SSA, they have at least one elevated marker. And these are markers against parotid salivary protein, secretory protein 1, and carbonic anhydrase 6. And so we have found over the years that many people carry these markers outside of Sjogren's. But to me, what they tell me is they help me identify a patient that I think may have a chronic inflammatory component contributing to their eye presentation. And the punchline is that not everyone who falls under the umbrella of dry eye needs the same therapy. Not everyone needs chronic immunomodulatory therapy. But if you have chronic inflammation, that may be a good category of patients. And right now I use short-term corticosteroids in my two long-term products. I have cyclosporin products and lifitegrast available to treat my patients who I think have a chronic inflammatory component that's driving their eye disease. But we have tried to figure out, can we predict who to give what to? And we found some people like cyclosporin, some like lifitegrast, some hate both. And we can't figure out, how do we get the best drug for the right patient? And so really in this field, what we need are better diagnostic biomarkers, and hopefully those are coming. And that's especially because there are other anti-inflammatory drops that are trying to make it to the finish line. I don't know what we're going to have, but it's still going to be the same problem. How do we figure out who needs what aspect of inflammation targeted, whether it's acutely or chronically? But there is hope. There are some companies that are trying to find biomarkers, like a anti-TNF alpha fragment that's trying to say, can I use a SNP in the TNF receptor 1 gene to predict effect? And at least in their early studies, they could. And so again, I don't know what we're going to have available, but this idea of applying precision medicine to dry eye is exciting. And I hope we have more studies and more biomarkers available. But as we all know, many times we think there's an inflammatory component, we treat it, and it's not enough. And the idea is that we need to address factors beyond inflammation in this umbrella term dry eye. And of course, one of the main punchlines is we need to understand nerve status in an individual patient. And we don't know nerve status unless we test it. You can test it with a cotton tip. You can use dental floss. You can get a little fancy and use the new Brill aesthesiometer. I like to just test the central. For grade 1, they barely feel it, not a good blink. Grade 2, a nice blink. They say, I felt it. And grade 3, they jump out of the chair, right? It's qualitative, but informative. And so in my patient, she has low sensation. She's barely feeling that cotton tip, and she has low nerve density. So thankfully, with just very easy tests, I'm able to say, you know what? Her nerves are not normal. And I think we miss that many people with lots of different subtypes that we call dry eye have a nerve problem. In my case, she has a grade 1 NK. And that's pretty common in Sjogren's, in diabetes, and other things, right? So the idea is if your corneal nerves aren't sensing, they're not giving the right information to the brain. The brain is not responding appropriately, and it can look like you have dry eye. You can have epithelial disruption and low tear production, but it's being driven by a nerve problem, and that's the key. So we need to figure out how to make nerves healthier or happier. I don't know how to do that, but there are a lot of different options out there that people are trying. And I can tell you that I do use a lot of blood products because they have been shown to help healing after an epithelial defect. And no one really knows exactly what they do. Maybe they just stay on the eye longer because of the protein. Maybe there are specific proteins like growth factors that help the epithelium and the nerves. I'm not really sure, but I can tell you I use them in many of my patients. Still questions on how much to use. I generally start with 20%, and whether we need to process them differently, like to activate the platelets to get more growth factors. All of those are options, but I consider these in patients who have a nerve problem. And there's more than one type of nerve problem. But again, when I look for decreased sensation in an epitheliopathy, that's when I consider them. But again, as I mentioned, there are other causes of grade 1 NK like diabetes. But the idea is not all nerve abnormalities come in NK form. Some nerves are hypersensitive, and it can happen with or without NK. And we use different words. Neuropathic, when there's a lesion or disease, like after surgery, you cut nerves and then people develop pain. Or nosoplastic, when you think the nerves are abnormal, but you don't see a lesion or disease. And that's more your fibromyalgia subtype. And that generally suggests that there's a problem in the brain. And the punchline is that treatments that treat pain outside the eye that is neuropathic or nosoplastic in nature can probably be applied to treat our patients with an NOP component. And so this is just another case where this highlights the point. When people have what we call NOP, they generally come in with different complaints. And you should be in your exam looking for spidey senses. You're looking for things like burning pain or pain that is radiating. So in my case, I'm sitting and looking for words that may suggest that there are nerve abnormalities, pain that is driven by light or wind. And so this is my patient. And so in her case, the symptoms started in a period of stress, and she has other things. She's a soft contact lens wearer. She has rosacea. So there are other reasons why she may have pain beyond her nerves. And so she already came to me with steroids, with serum tears, and on some oral neuromodulatory therapy, but she wasn't happy. And fortunately, her vision was good. But what I like to do is I like to use standardized questionnaires to understand what patients are complaining about. And I don't like to just look at the totals, but I like to look at the actual sub-questions, because to me, eyes that are sensitive to light mean something different, nerve abnormalities, to eyes that feel gritty. That's more nociceptive, a problem with the ocular surface. But this is a nice way to kind of pick whichever questionnaires you want so that you can quickly figure out what patients are complaining about. And then I start thinking about the different causes of pain, because there are things that make nerves unhappy that we can see. We call those nociceptive, and then the nerve abnormalities. So again, she has a little rosacea. Many people do. She does not have conjunctivitis. She has just a touch of inflammation, but less than our patient. You can see that the pink stripe is less intense. She does have some vascularity, probably consistent with rosacea, but her anatomy is normal. And with one stripe, I'm able to see that she does have tear instability and a little bit of staining, interestingly, in the superior quadrant, and she does have low tear production. So she does have a component of dry eye, but she has a lot more going on. And again, patients are complex, and she's mapping out to a pattern of SLK, but clinically, she doesn't look like she has SLK. But of course, that's not enough. We also need to think about nerves. And I already have a sense that her nerves are not normal because of the way she's complaining about her sensations. While her corneal sensation on testing is normal, she has sensitivity to light touch around the eye. And the most important test is to see what happens to the pain when you put in an anesthetic. And if it doesn't change, it's probably not coming from the ocular surface. And so that's when you start thinking about, well, where else is the pain being generated? She also has pretty normal nerves without inflammatory cells. And so to me, just like we have a checklist to tell us what are we looking for on the level of the ocular surface, I also have a checklist to tell me when do I think there's a nerve abnormality. And pretty much the more checks you get, the more likely it is that there's probably a nerve abnormality that's driving the pain. But patients are allowed to have more than one thing. And this is actually what my note looks like. She has pain. I think that there are components that could be neuropathic nociplastic, and also I'm seeing some things on a nociceptive basis. So the key is I always treat what I see, but fortunately she came in already treating what people saw. So I thought, all right, let's try to do something different. And the goal is to get to Goldilocks, not too little, not too much, to get patients to good enough. And so I talk to all of my patients because if you constantly feel your eyes, you're upset about it. And we talk about active versus passive coping mechanisms, figuring out how to live with your pain versus letting it define you. Then we talk about the environment. Some people find that trying to find glasses that block out the things that irritate them are really helpful. Then we start talking about neuromodulation. And again, everyone has a little different approach, but in her case, because the pain did not get better with anesthetic, I'm localizing it to the brain, and I'm trying to get a cocktail of neuromodulators that I think may help her. And not the topic of today's discussion, but happy to talk about it with anyone offline. Always love to talk about neuromodulation. And the key is we kept on tweaking, and she was better, but not good enough. And 8 months later, with a little bit of a more tweak, we got to good enough. And so what's really important to recognize with pain, and especially with neuropathic or nociplastic pain, that it's like watching paint dry, okay? It takes slow and steady wins the race, but eventually we're able to get to a regimen that get people better. And so What are the mid take-home points are that individuals are complex. There are many contributors to pain and discomfort. And what we need to do is have a systematic, quick way that works with your clinical practice to try to identify the contributors in an individual patient. And that in some patients, it's abnormal nerves that are driving the process and that they can be targeted as well. And the punchline is really when you use the word dry eye or dry eye symptoms, it doesn't actually mean dryness. Actually, a minority of people have dryness, and there are so many other causes of symptoms that need to be considered. And that's why it's important to recognize that it's not just dryness. It's not just the lacrimal gland. It's also eyelid and meibomian gland and anatomy that needs to be considered. And that is also controlled by this LFU that we keep on talking about. And just like this umbrella term of dry eye, the umbrella term of MGD can mean different things, right? You can have a problem with your eyelashes. And if it's, these collarettes hugging the base of the lash, we know that there are Demodex hiding there. I used to pluck these and look at them under the microscope. They were always there. So now I just know you don't need to do that. And the key is that sometimes we need to treat that. Scurf is different. That is when you have debris, but it's not touching the base of the lash, often associated with periocular skin diseases that may need to be targeted. And of course, the idea, who do I treat and how? Still an evolving conversation. But the punchline is, if I see a huge Demodex load, I think it's nice to try to reduce it. And there are many different ways to do that. If I see rosacea-associated changes, so vascularity, hyperemia, I like to try to target rosacea. And you can work with the dermatologist or have a few tools up your sleeve on how you treat rosacea. I do like short-term topical steroids and also oral antibiotics. And it's interesting because we tell patients that they do more than just change your microbiome. And there have been studies that show that they do decrease inflammation, both doxycycline and azithromycin. And then they may affect myocytes and cause lipid changes. And so again, I don't know which one is best, but I do like them. And I also do like treating the periocular skin. I like IPL. There are other ways to do it. And pretty much what I do is I just try to have a IPL treatment that's like a raccoon. I do overlapping treatments around the periocular skin, and I try to do 2 passes on each spot. I repeat it 3 times. And what I do, I want to tell my patients, I want them to look like Santa Claus, like a nice rosy glow when they're done. But it's important to recognize there are many different ways to address MGD. We don't know which one is best for which patient, but the idea is it's really important to phenotype and then consider what we need to address. And then again, we're talking about the lacrimal gland, we're talking about the meibomian glands and the eyelashes. It's really important to think about anatomy. I've had patients who come in and they say, my left eye feels gritty and I was diagnosed with dry eye. And I look and obviously they don't have dry eye. We know why their left eye feels gritty, right? So kind of taking a step back, not using the word dry eye, and thinking holistically about sources of pain are really important. So again, things to look for. Ectropion, pretty easy, but entropion is often missed. And again, what you're looking for is a clue. When you see inferior PEE, you have to really look at eyelid function and see if you're missing something. And sometimes it's not obvious and you really need dynamic testing to bring it out. Look here at the right side. It's really when you get a nice squeeze, then you start seeing the lashes come in. So what do? I step into the room, I'm looking at the periocular skin, then I look at the blink rate, then I ask them to gently close their eyes, then force closure, and then I pull up and down. And that is kind of my quick and dirty way to get an overall view of anatomy. And so this is one of my patients, of course, diagnosed with dry eye, and he does not have dry eye. This is him trying to just gently close your eyes, and you're seeing the lag of thalamus. And here is force closure. And you can see that with force closure, we're still having a problem on the right side. And this is after a gold weight has already been placed. So again, I don't know what's the best way to manage these anatomical changes, especially post-surgical ones. But this is a device that I've been following that I think is pretty cool because it allows patients to blink and it's controlled by your phone. So one thing that I'm offering to my patient. And this is the pull up and the pull down part. And again, unless you test for it, this anatomically doesn't look bad. So you don't get a sense of laxity and anatomy unless you actually look. And so again, here's another situation where someone was diagnosed with dry eye, but when you pull down aggressively, all of a sudden you see, hey, what is this symblepharon doing here? This is cicatrizing disease. This is a chronic cicatrizing conjunctivitis. And of course, this has to be treated differently and of course diagnosed. And it's not just about pulling up, really important to pull up on the eyelids and have patients look down. Now, this is something I can't fix. I know why this patient is feeling gritty. She has a huge bleb, but her pressure is 9 and I'm not doing anything about it. But sometimes you find things you can do something about, like SLK. And so then it's important to look. And again, we talked about consistency being the key. You look here, looks pretty good. You have to flip the lid every single time you do an exam for ocular surface disease, because this is a retained stitch that was irritating and would have been missed if the lids weren't flipped. So the key is, as part of your ocular surface exam, always flip the lid. Then we go to the conjunctiva. And this is a patient, again, who's reporting grittiness. So I'm already thinking there could be a nociceptive component. And he has no tear lake peripherally because there is significant conjunctival cholasis and an expanded tear lake centrally. And you can see with fluorescein, and this is why vital dyes are so important to your exam, that there is almost no tear lake because of the folds in the conjunctiva. And oftentimes when you have anatomical changes, you also see a lot of inflammation. So inflammation doesn't always mean a systemic autoimmune condition. And the key is, again, there are so many different ways to address conjunctival cholasis. My favorite is a little bit of cautery applied right in the clinic. But the key really is not about treatment. It's about making the right diagnosis, understanding what the contributors are, so you can figure out how to treat them. And this is what patients look like at 1 week, which is why I don't see them anymore at 1 week, because they look pretty terrible. But by 1 month, they look really good. And many patients who have significant cholasis that was missed, they do really well with a relatively simple procedure. So I know that was a lot of material, but the take-home point is that the ocular surface is complex and tear homeostasis is complex. And it's not just the lacrimal gland. It's the lacrimal gland and the meibomian glands and the goblet cells and the anatomy and the conjunctiva. And what keeps it all going, the like silent conductor of this orchestra, is what we call the LFU. It's the sensory system that tries to understand what's happening at the level of the ocular surface, sends information to the brain, and has the brain appropriately respond. But as you can see, there are so many things that can go wrong in an individual patient. And that's why we should never use the word dry eye, because it just really limits us into thinking holistically about all the different areas that can go wrong. You can use the word as long as it's a concept, but if it's like one thing, don't use it. Instead, try to understand what you're seeing at the level of the ocular surface and target it. And look for other abnormalities. Look for eyelid issues, anatomical issues, MGD, the whole spectrum of MGD. But also really important to think about nerve issues, both NK and NP. And it's important to think about them in a consistent manner that's quick but comprehensive, so you can figure out how to treat. And thankfully, I have my colleague, Dr. Magpara, who's going to take this is the easy part, the diagnosis. The question is how do we treat these patients? And so I think what I'm going to do is I'm going to ask the same question, my post-test question. Again, it's my patients with Sjogren's. She's not doing well with lubricating drops. And what would you do? And then I'm going to pass it on to you, Dr. Magpara.
Thank you very much. And we have, while you guys are doing the poll questions, we have a few questions from the audience. Keep them coming. We will definitely have time at the end to go over all of these and talk about the questions that you have.
Okay. I have to say, am I allowed to say? I guess I'm allowed to say yes. I think that in someone with autoimmune disease, a chronic anti-inflammatory therapy is a good start. It may not be enough, but it is a good start. Okay. I love it. Okay. So now what I'm going to do is I'm going to stop sharing.
All right, so that was an amazing talk on the diagnosis of dry eye, the complexity of dry eye, how to think about dry eye. So now I want to focus a little bit more on the treatment of dry eye, especially looking at utilizing neuromodulation and some of the new pharmacologic options that we have or may have available to us in the future. So I'm also going to start with a question. So my patient is a 55-year-old female. She's been diagnosed with moderate dry eye disease. And she's been frustrated in the past with how long some of the medications that she's tried take to work. So she was started on acoltremon. And the question is how quickly will this work? So what um, is the rate of increased tear production that we see in the pivotal trial? So does this start to work in as little as 1 day, 1 week, 1 month, or 6 months? So we'll give you guys a few seconds to uh, think about that and answer that. All right, very good. So we have a nice variety of answers here. So I'm not going to give you the answer yet, but pay attention during the talk, and then we'll re-ask the question. All right, so again, I want to talk about some novel neuromodulation-based therapies that we use for dry eye. And again, my name is Biren McPara. I'm from Philadelphia, Pennsylvania. So this concept of neuromodulation or neurostimulation, it's nothing new, but it is something new in the eye care world. So what is neuromodulation? So it's basically we're modifying nerve function using a specific stimulus, whether it's electrical stimulation, magnetic stimulation, pharmacologic agents. But we're looking to target specific neurological targets. And you can use different devices. So the term neurostimulation usually describes a device where you apply electrodes to the brain or spinal cord or peripheral nerves to send the stimulus. And it's been used in other parts of the body for quite some time now. So it's been used to treat bladder dysfunction, chronic pain conditions, dystonia, epilepsy, deep brain stimulation for Parkinson's. It's been used for psychiatric conditions like obsessive compulsive disorder, Tourette's syndrome. So quite a bit of use in other parts of the body. But over the last few years, we're starting to utilize this concept for the treatment of ocular surface disease. So we have an external neurostimulator. It's called the iTear 100. And I'm not sure if a lot of people know about this device. It isn't super popular and a lot of people don't know about it. But what it is, it's a stimulator that you put outside of your nose. So you touch the external nose, and what it does is it stimulates the external nasal nerve through kind of an oscillation. And this was approved in 2020, and it's used for the treatment of dry eye. There was a previous device that was inserted into the nose to kind of do the same thing, but that really isn't on the market anymore. So the question is, how does this work, or how well does it work? So this was studied, and this is a multi-center open-label single-arm trial looking at patients with dry eye disease that had a baseline Schirmer's of less than 10. And there were two endpoints that this study looked at. It was the increase in Schirmer's score compared to before using the device to after using the device, and then dry eye symptoms, so the OSDI index. And at day 30, patient had a mean increase in Schirmer's after using the device of 9.4 millimeters. And this was seen kind of at first use. And as the study went on at day 30, there was a decrease in their OSDI, so a decrease or an improvement in their dry eye symptoms with just two mild device-related AEs. So the question is, how does a device that you apply to the skin outside of the nose help treat dry eye? And this utilizes the concept that Anat described so well, this lacrimal functional unit. So it's always good to review. So what is the lacrimal functional unit? Well, it's a combination of afferent neurons and efferent neurons. So you have this afferent neural network that detects things on the ocular surface. Um, it sends that information to the trigeminal ganglion. It goes to the central nervous system. And then we have this efferent system that talks to all these components on the surface of their eye that are responsible for creating a basal tear. So, like meibomian glands, the lacrimal glands, the goblet cells. these structures are stimulated so that they produce the components that they're supposed to produce, right? So it's all about the nerves and it's all about the receptors, right? This neural network. This is something that, some of this is intuitive, right? So the mechanonociceptors and the polymodal nociceptors that Dr. Gallar talked about, these respond to noxious things, right? So mechanical stimuli like an eyelash on the surface of the eye, or chemical stimuli like the vapors of an onion, or thermal stimuli like extreme heat or extreme cold. These are going to stimulate these receptors and stimulate a reflex tear. And this is intuitive, right? This concept makes sense to us. We've been used to this our entire lives. But there's this other category of receptors, these cold thermosensory neurons, that honestly I never really thought a whole lot about. Now, if you think about it, something 24/7 all the time is stimulating or telling the different structures on the surface of the eye to produce tears, right? This is happening all the time in the background. So what's talking to that, or how does that happening? And it's these cold thermosensory neurons that are responsible for that. So what these neurons do is they detect small reductions in temperature on the ocular surface that's associated with interblink evaporation. So what happens is when you close your eyes, the ocular surface temperature raises ever so slightly, and then when you open the eyes, that ocular surface temperature cools. And we're just talking a few degrees here, but we have a receptor on the surface of the eye, the TRPM8 or the TRPM8 receptor that detects that subtle decrease in temperature. And compare that to these other receptors that detect extreme heat or extreme cold, and those would create a reflex tear, right? So if you go outside in the cold winter, you're going to get tearing, and our patients tell us all the time. But that's not the TRPM8. The TRPM8 detects kind of this baseline subtle decrease in temperature that happens all day, every time you blink. So we could take advantage of that concept when it comes to creating a medication to help stimulate that basal tear production. So acoltremon is a potent and highly selective TRPM8 agonist. So when acoltremon is applied and it activates those receptors, what it's doing is it helps stimulate basal tear production. It helps stimulate the lacrimal gland, the meibomian gland, and the goblet cells to secrete a nice basal, healthy physiologic tear. So this concept or this medication was studied in two pivotal trials, phase three trials called Comet 2 and Comet 3, and the medication was FDA approved, and now it's known as TRYPTYR as the commercial name. But as far as the study goes, it was a one-to-one trial, vehicle controlled, acoltremon 0.003% versus vehicle, dosed twice a day, and patients were examined at day 1, day 7, day 14, day 28, and day 90 was the endpoint of the study. And what were the endpoints? So what were we looking at in these trials? Well, this is meant to increase basal tear production. So the primary endpoint was that. It was looking at the proportion of subjects who achieved a greater than 10 millimeter increase in baseline in their Schirmer score at day 14. And that greater than 10 millimeter threshold, that's kind of a standard set forth by the FDA historically. So other endpoints, so the primary endpoint was measured at day 14, but we wanted to know, how quickly does the medication work? So there was a measurement done at day 1, and does the effect wear off? So the measurement was also done at day 90. Other things that were looked at were Sandy scores, so looking at the improvement in symptoms of dry eye, and then also corneal and conjunctival staining, which we all know is very important in our ocular surface disease patients. Demographics, this was kind of your typical dry eye demographics. So the majority of patients were female and Caucasian, but there were males in the study, and African Americans, Asians, and other races were represented as well. As far as baseline characteristics, these patients had a mean Sandy score of about 70. So for those of you that don't know, the Sandy score is a score that rates the frequency and severity of dry eye symptoms. It's rated on a scale of 0 to 100, 100 being the worst. So a score of 72 is moderate to severe dry eye patients. And they all had a low Schirmer score with a score between 5 and 6. And that was the same for the vehicle and the treatment group, as well as similar in both studies. So if you look at the results, so again, the primary endpoint was the percentage of patients that had an increase in Schirmer score of greater than 10 millimeters compared to baseline. So this is a pretty significant increase for those of you that do Schirmer's testing in the office. Having an increase in 10 millimeters is a pretty significant increase. And when you look at the two studies and you compare the acoltremon group with the vehicle group, there's a 3 to 4 times number of patients that did meet that primary endpoint when you look at the treatment group. So between 42 and 53% of patients had that increase of greater than 10. Now, that doesn't mean the remaining patients didn't see an increase in Schirmer's. They just didn't hit that threshold. So, if you had a 9 millimeter increase or an 8 millimeter increase, you're not counted here. But it still met its primary endpoint at day 14. So then the question is, if you look at the pooled analysis, again, a lot of our dry eye patients are frustrated by how long it takes for some of the current medications to work. How long does it take to see relief, to see increase in tear production? So at day one, 3 minutes after installation of the medication, we saw that increase in tear production. And then the question is, what happens if you're constantly stimulating that receptor, twice a day, every day for several days? Does the effect wear off? Do you get used to it, or what we call tachyphylaxis? And at day 90, we saw that that effect was still there. So 53% of patients had that greater than 10 millimeter increase in Schirmer's score. So it was nice to see that it was a quick onset and the effect persisted all the way to the end of the trial. Now, when it comes to symptoms, which is very, very important, I always tell our residents and fellows, patients will come to you for 3 reasons. They don't feel good, they don't see well, and they don't like the way they look, meaning their eyes are really, really red, right? So if we can fix one of those, it's a win. So when it comes to symptoms, that's really important for dry eye medications. And when you look at the reduction in the global Sandy score at day 28, we see about a 20-point reduction in symptoms. Now, remember, they started at about 75. So if you get a 20-point reduction, that's a meaningful reduction. And in one of the studies, it was statistically significant compared to the vehicle. And in the other study, in Comet 2, it was clinically significant. So it didn't have a statistically significant difference compared to the vehicle, but there was still a reduction in that Sandy score. And then again, if you look at the pooled analysis, if you look at as early as day 7, we start to see a reduction in that score. And as you go further and further out in the trial, like a lot of dry medications, the more you use them, the more effective they're going to be. So at day 90, that's where we see the largest decrease in Sandy score, which was the end of the trial. So it's encouraging to see that this medication does help the symptoms of dry eye in our patients. And then when we look at corneal staining, we do see a reduction in corneal staining compared to baseline. On this graph, the blue line is the acoltremon group, the gray line is the vehicle group. And the way it's depicted here, you want the line to be lower. So the lower, the better. That's indicating a reduction in corneal staining. So we see a reduction in corneal staining in the acoltremon group. And we also see that staining continue to get lower and lower as the time points get further and further out. So the more you use it, the staining got better and better. So as far as efficacy goes, this medication was FDA approved. It is FDA approved. It's available to use. So the efficacy was there. It met its endpoints. There's an interesting phenomenon with this medication, and that involves kind of tolerability. So in the trials, 50% of patients reported this, burning or stinging or pain upon installation. So when you look at that, you're like, whoa, that's kind of high for a medication, right? When you dig deeper into the numbers and you kind of categorize that or classify that, of those patients, 98% reported that sensation as mild. And looking at some long-term studies, which was the Comet 4 study, 86% of those patients reported that the sensation lasted 1 minute or less. And then, you always look at discontinuation rates in FDA studies, right? So less than 1% or 0.7% of patients who were enrolled in the study discontinued it because of the way it felt, or they felt that it was not tolerable enough to continue. So it is something that if you're going to start your patients on this medication, it is really important to tell them that they are going to feel something. Um, and it's not unexpected. It doesn't mean that anything's wrong. If you think about it, this medication is stimulating a nerve, right? And when you stimulate a nerve, you're going to feel something. So in my experience, as long as you tell patients about it, they know what to expect. That's going to increase compliance. It's going to re result in less phone calls to your office. Um, and that's what I'll tell them. So I'll tell them when you use this medication, you'll feel that it went in the eye. Often kind of joke, like you'll know that you got it in the eye. You know that you didn't miss the eye. Um, and then it's typically mild and it's short lasting. And then after that, we'll start to see the effect of the medication. So again, just important to disclose that when you're talking to your patients. It's a quick conversation. So that was using a drop, a neuromodulator drop to help stimulate basal tear production. There is an alternative pathway to do this too. So it's a nasal spray, and that's varenicline. And varenicline, which is also FDA approved, the trade name there is Tyrvaya. And what Tyrvaya does is it activates the trigeminal parasympathetic pathway via the nose, so a nasal spray in the nose, which then results in basal tear film production. So again, it stimulates the lacrimal gland, it stimulates the lacrimal functional unit, right? So the lacrimal gland, the meibomian glands, and the goblet cells to help create that nice basal healthy tear that we like to see on the surface of the eye. So very similar design studies, meaning looking at the looking at similar endpoints. So the FDA pivotal trials here were called Onset 1 and Onset 2, and it looked at tear production and increase in Schirmer score of greater than 10 millimeters at week 4. And again, when you compare the two groups, when you compare the Tyrvaya group versus a vehicle that was sprayed into the nose, we see a statistically significant increase in that tear production when you compare it to the vehicle group in both studies. And again, this was at week 4. But the question is, how quickly does it work? And it's a recurring theme here that after the first dose of Tyrvaya, there was increase in Schirmer score. So it's it kind of reinforces the fact that when you utilize the nerves, when you utilize neuromodulation, you get that effect essentially right away from the first administration. So you get that tear production, whether you use a drop or whether you use a nasal spray. By stimulating those nerves, you're getting that tear production to almost instantaneously increase. Now, as far as symptoms go, um, in the onset 2 study, using the eye dryness score. By week 2, there was a reduction in that score, and it was statistically lower than the vehicle group. And this, like the TRYPTYR medication, continued to get better and better as time went on, as patients used this medication more and more. So the last medication I want to talk about is something that exists, Synedromine, which is recombinant human nerve growth factor. And in its current form, it's approved for the treatment of neurotrophic keratitis. So, right, this is FDA approved in the United States. The trade name is Oxervate, and it's approved for the treatment of neurotrophic keratitis. Um, and neurotrophic keratitis has a variety of presentations, right? So we'll start with the worst. So stage 3 NK, there's something called the Mackey classification guide. So in stage 3 NK, we have an epithelial defect and we have stromal ulceration. You have stromal thinning underneath that epi defect. Stage 2 is probably the classic NK that we think about. It's this non-healing persistent epithelial defect, typically central or inferior paracentral. It's often round and you often see these rolled edges. But then there's also stage 1 NK. And if you think about NK, NK is kind of it's a continuum of a disease, right? Patients don't start at stage 3. They have to start somewhere, and they start at stage 1. And stage 1 NK, like Dr. Galore, showed us so well in her pictures and in her talk, it can resemble quote unquote dry eye, right? So you get this punctate epithelial staining. Typically, it's central or inferior paracentral, and there's a lot of overlap, right? So a lot of patients with Sjogren's have some degree of NK. Patients with chronic dry eye can have NK. Patients that are long-term contact lens users have a component of NK. So oxervate has been shown to be efficacious in the treatment of NK, but can we also utilize this medication in dry eye? And that was the question that was studied in a phase 2 trial for dry eye disease, looking at moderate to severe dry eye patients, including patients who had Sjogren's, who were treated 4 weeks with Synedrimen. And there were two arms in the study, either using Synedrimen 3 times a day or using it twice a day. Now, it should be noted that it's the same concentration that's used for neurotrophic keratitis, but the NK dosing is 6 times a day, right? So this trial looked at can less frequent dosing be effective in dry eye patients. So the first thing that was looked at was Schirmer's score and the change from baseline. And there was an increase in Schirmer's in both the Synedrimen groups compared to the vehicle, but it didn't meet statistical significance as far as the change in baseline. Um, Symptoms, however, in the TID group, there was a reduction in Sandy score, so a reduction in symptoms compared to the vehicle group and also compared to the twice a day group. So it looks like the 3 times a day dosing of Synedrimen did decrease dry eye symptoms. This is a phase 2 trial, so there's still a little bit ways to go here. But it's just another way to think about corneal nerves, another way to utilize corneal nerves for the treatment of dry eye. So to summarize, this is kind of a new way to think about dry eye, right? For many, many years, we thought of dry eye as solely an inflammatory disease. And it is certainly an inflammatory disease in a lot of patients. And certain diagnostic testing and taking a good history and looking at signs on exam are really important to look for signs of inflammation. And if you see signs of inflammation, you have to treat those signs of inflammation. There's no arguing against that. But that may not be the whole picture, right? What else can we do or what else can we utilize to help increase healthy basal tear production? And neuromodulation can help us do that. So we have two products available to us right now, acoltremon, which is a TRPM8 agonist, and in phase 3 trials, we see rapid improvement in Schirmer scores, reduction in symptoms, so an improvement in the Sandy scores, and a reduction in corneal staining. And then varenicline, which is a nasal spray, um, neuromodulates or stimulates tear production via the nose, and this yields a rapid increase in basal tearing and reduction in dry eye symptoms. And then, down the road, what else could we potentially expect? Using recombinant nerve growth factor, which may have some therapeutic promise to treating moderate to severe dry eye patients and patients that have Sjogren's. So thank you there. Now we're going to pull up the same question here. So again, we have that 55-year-old patient. We started them on acoltremon, and the question is, how quickly is this going to work? So when are we going to see that increased tear production? So as early as day 1, week 1, month 1, or 6 months. All right. We did better. Perfect. So yeah, increased tear production was first noted as early as day 1. Um, after using acoltremon. All right, so now what I'm going to do is I'm going to stop sharing, and I think we have a bunch of questions. All right, so I think some of these are not you mentioned, but there's a few things here on IPL and its use in blepharitis. So um, I guess I'll have you start. What do you utilize IPL? What patients do you think work best? And kind of what's your experience been there? And then I'll chime in.
Right. So, first of all, that was excellent, and I loved it. And I love thinking about dry eye, the concept as a multifactorial disease. And I think there's room for everyone. And what we need to do is figure out how do we get all these amazing treatment options that we have to the right patient. And I don't know all the answers, so I can just give you my opinion, and I'd love to hear yours. So I do like IPL in two categories in my rosacea blepharitis patients. And how do I define that? Well, I see skin rosacea, I see telangiectasias, I see eyelid hyperemia, and prior studies have shown that this population of patients have inflammatory cytokines and that IPL treatment may reduce those. Now, these aren't robust randomized controlled studies, but I feel like the chance of doing harm is low. Patients seem to like it. But what I would say is, even in that category, there are some people within that category that really perceive a clinical effect and others that don't, telling us that there are probably other factors that we still need to discover. The other category I use it in are people with chronic chalazion. And that's pretty much because that's what's in the literature is maybe helpful. The data is even less robust on that one. But again, these are patients that are so frustrated. And I've tried kind of the traditional things. I don't love surgery for chronic chalazion. I worry that I create more scarring and future potential for more chalazion. So this is something that I like. And also people with high Demodex loads that I can't get it down in other ways. And so those are kind of my three categories, with the biggest one being rosacea associated disease. But even within those categories, there's heterogeneity of response. I do avoid it in people who are super pigmented, and that is probably my own comfort. I'm sure other people may have different strategies or different machines, but Fitzpatrick 4 and 5, I don't do IPL.
Yeah, I
What
mean,
about you?
yeah, I mean, you were spot on in that, there's not a plethora of data out there, especially, randomized control data. So a lot of this is anecdotal for me. So when I look at the lids, when I think of procedural treatments, I kind of try to split it. Like, would this patient benefit from a thermal treatment to help heat up the glands and open up the glands, or a light treatment? And I kind of base that off of kind of severity of disease. So if I have someone with glands when I press on the eyelids and we are getting meibum, but not as well as we like to, I'll often start with a thermal treatment there. But if they have these really inflamed glands, rosacea, scarring, and there's a significant inflammatory component there, then I will lean towards the IPL side. But there's overlap there, right? So, some studies will tell you that, IPL will also help improve gland flow and is there a thermal component there as well? But I like to stratify kind of based on severity of disease. I do like it for that chronic Demodex population as well. As a follow-up to that, are there any contraindications to IPL?
So that's the skin type. And, it's not a hard contraindication. It's just that I just don't use it in that practice. But I know there's a lot of talk about maybe us not having the most robust protocols in people with different skin types, and that maybe we should do better to figure that out. So I have to look more about it. Right now, IPL for me is Fitzpatrick 1, 2, and 3. And mostly the 3 are the people who are like the chronic chalazion sufferers. I have actually also been burned on the Fitzpatrick 1 people who are really, really fair skin. Sometimes they have like a weird hyperpigmentation to IPL. And if someone has a bad outcome, generally it goes away. But generally, if my first treatment doesn't go well, then I don't offer it again. But, I've been doing IPL for a long time, and I would have to say that it's a generally benefit outweigh risk kind of procedure, and patients either love it or it does nothing for them. But I don't think I've hurt that many people with IPL, so it is one of my favorite tools in the appropriate population. And again, that's to me the big question is, and I love that we all have our gestalt. Hopefully we'll, as a community, come together and do better, but figuring out what are the clinical parameters that can tell us who does best with what, especially as we have this expanding arsenal of office-based procedures, neurostimulators, inflammation, right? How do we figure out who needs what? And so I think that that is something we really need to do as a community. But I agree with your gestalt. I also like to look at function, and I find that my rosacea blepharitis, they actually, you can express, and their expression generally is kind of oil-like. It's more the inflammatory load. Then there are other people who look pretty good, and you squeeze and toothpaste comes out.
Yeah.
And to me, those are two different populations. We need to figure out how to, operationalize those findings into treatment algorithms.
Yeah, looks like there's a lot of interest here in eyelids and eyelid-based dry eye and evaporative dry eye. So one of the other questions that came up is, and this is really common, right? So what measures do you recommend for the dry eye patient who has prolonged daily screen time? And mine is the obvious, stop using the screen so much, but I mean that's just not practical. So what do you tell these patients?
So I think for me, I need to be very clear about what I know because there are clinical trials and what I know because of Gestalt. Like it seems to me that if you're using your screen 16 hours a day, taking breaks makes sense. Do I have a clinical trial that shows that that's true? No. But I just talk to my patients, like maybe set a timer and every hour go walk around and blink. And I don't know that I'm doing anything, but it makes me feel better to be able to give a recommendation.
Yeah, for me, actually, it's these neuromodulator medications that actually I find pretty helpful in these quote unquote evaporative dry eye patients, just because you get that complete tear, right? So whether you stimulate through the nose or via an eye drop, we have studies that actually show that you get an increase in lipid concentration with these medications, right? And that will help decrease the amount of evaporation. So, I do have a little bit, before I would, just say, warm compress, maybe we'll do some sort of thermal treatment to your eyelids. But now in these kind of evaporative like patients, younger patients, these patients are coming in at younger and younger ages. I'm using some of these neuromodulator medications. And they've been
And I
pretty.
would love to see the data, right? So I love that now that we have this, I would want to see phase 4 studies to say, hey, within this group of patients that have dry eye symptoms, these are some things that predict response. And if it's using your screen for 16 hours a day, that's great because that's something I can ask my patients. So I think we should kind of record these gestalts and then try to test them to figure out who are our super responders to any strategy.
Yeah, no, I mean that's the golden ticket, right? If we could figure out an easy way, a scientifically proven way to tailor all these different treatments, whether it's neuromodulation or anti-inflammatory, and just get the right medication to the right patient, I think the treatment success rate for dry eye, which historically has been pretty frustrating, right, for um, kind of the general practicing population, I think it would become a much more satisfying disease to treat.
Could not agree more.
All right, last thing, let's talk a little bit about Demodex, Xdemvy. There's a couple questions about just kind of what was here. Have you ever seen this? Eyelash loss with lid hygiene wipes.
Yeah, I have. And I honestly don't know if I attribute it to a specific wipe or just patients being really, really enthusiastic
Yeah.
about eyelid hygiene. I do talk to my patients that gentle hygiene is good and they don't need to like excoriate their skin. That's where I start. I'm more of like a less is more. Like again, that's why I say Goldilocks. I just think just because you can do something doesn't mean you should. And to me, it's finding that right combination that's no more than you need, but no less than you need. And I think lid hygiene does make sense, but there are some patients and patients are suffering. They have symptoms that they can overdo it. So I do like to talk to patients about, being gentle. Um, and I don't think that there's one way of doing things, but I do think that if you're going to be using lid hygiene, use a product that's meant for that. So I do not like baby shampoo. I like products that are meant for the eyelids.
I think that's a great pearl that we should end on. It's sometimes less is more, or the Goldilocks kind of mentality. We both work in residency programs, and sometimes we'll talk to our trainees and they want to start like preservative-free tears every hour, ointment three
Every
times
hour.
a day.
Like it's so
Exactly.
mean.
Lid hygiene, warm compresses, this, that, and the other. And like this individual is just going to spend their whole life taking care of their eyes, and that's just not a way to live. So yeah, again, targeted treatments, thinking about what the underlying cause is, what's the one or two treatments that we think will work best in that patient. And I think that's a great way to approach dry eye. So I think with that's a great way to wrap up the program. Just want to thank you and everybody out there in the audience, especially for joining us on your Saturday morning. Hopefully you found it useful and you came away with at least one thing that you can take back to your practices. All right. Thanks, everybody.
Thank you.